Dear colleagues, this is phacoemulsification of a hard, white, non-intumescent cataract. I have started the surgery. Let us see how the surgery went on. The lid margins are nicely covered with plastic drape. Now the ocular surface is thoroughly washed, applying few drops of betadine 5% lotion. There should not be any discharge on the ocular surface. It must be very thoroughly washed. Few drops of moxifloxacin applied, and now we're going to start the case. This is the main incision. This is a 2.8 millimeter sized keratom, and you can see some few drops of blood is oozing out. So this is a posterior limbal incision, including the blood vessels. Now the anterior capsule is stained with trypan blue dye underneath an air bubble, and after a few seconds the dye is thoroughly washed out. Now we are going to use a viscoelastic substance. In this case it is hydroxypropyl methyl cellulose 2%. This is a non-intumescent cataract, so I will be able to do rhexis at one attempt. So the anterior capsule has been incised and a nice flap has been raised. Now I hold this flap with a Utrata forceps, go anticlockwise and make a continuous curvilinear capsulorhexis. Try to be at equal distance all around from the margin of the dilated pupil, and you will not need any rhexis marker. That's it. Rhexis is done. Now a bit of fluid is passed underneath the anterior capsular rim. The nucleus is gently depressed and it is mobilized. Again, some amount of viscoelastic substance is injected, and now is the time to enter into the eye with the tip of the phaco handpiece. The tip is introduced bevel down. Now it is turned and it is made bevel up. Now here I am doing submarine chop. The tip is buried deep into the substance of the nucleus, goes towards the opposite equator, remaining buried, and thus I can make a nice crack. So the nucleus is held at several points and some chops are. Now see here, this is the endonucleus. Once I remove this endonucleus, the pieces become separate. Before this, the pieces, the fragments, were attached to the endonucleus. Phaco power used in this case is 80%. Flow rate is 45 ml per minute. Vacuum is 450 mm of mercury. The machine being used is Oakley Catarix 3. It's a beautiful machine, no financial interest, but it is very efficient. Chamber remains stable, very stable. That's it. Now some cortical lens matter is remaining. we have to clean that. I'm using a 23 gauge Simcoe cannula to remove this cortical matter. In this case, I have made only one side port, and the side port size is about 1.4 millimeter, and the 23 gauge slender Simcoe cannula can go through it very easily. Now this is hydro polish using the irrigating probe to polish the posterior capsule. In this case, I have selected a hydrophilic acrylic intraocular lens, and here is the lens. The patient belongs to economic category and he cannot afford hydrophobic lenses. But this is a beautiful lens from Appasamy Associates. It's called NASPRO, no financial interest again. The lens has been placed nicely in the capsular bag. You can see a rim of capsule is overlapping the optic all around. And once this happens, the lens never tilts and remains nicely centered. Now this is moxifloxacin. Now the side port is hydrated. The side port is hydrated, stromal hydration, so that the cleft closes. And now is the final wash with BSS, viscoelastic substance that remains attached to the corneal endothelium is removed at this stage. That's it. Now the case is done. We just have to form the entry chamber and conclude the case. This is a routine case, but this is very useful for the beginners. And my dream is to develop the beginners to make them excellent world-class surgeons so that the blind people get very good vision.